necessary to write, yeah, you can make the notes, but don't just write all my speech. We will make a huge big picture after. But firstly, let's introduce for you some organs. And let's start from the spleen. You know my style. Previously, before to speak about topographical anatomy, I try to show for you surgical importance of the structure. Same I do for all another organs, yeah, which we study. Now, what is the surgical importance of spleen? I can mention two problems of the spleen, which is mainly need to be surgically treated. And problem number one, it is the traumas of the spleen. You remember that the spleen is parenchymatous organ. It has very soft body, and more of this, it has the accumulated blood inside of it. As you remember, this is the place of deponization of your blood and the eliminations of all the erythrocytes. Yeah, hemoglobin is divided into several fractional units here. Car accidents, polytraumas, any different kinds of knife, gun, and anything else simply damage the body of the spleen with formation of the huge, very profuse internal bleedings. And the main treatment which we perform in that case is we call splenectomy. I will teach you what we do in case of spleen. Yeah, unfortunately, guys, if there are huge, big ruptures of the spleen tissue, suturing is not so effective because take in your home, for example, plastic bag with the water and try to suture it. Any place of your perforation will be the new place of the bleeding. That is done. We have the type of the sutures of the spleen, but only in the case of small, very small damagings. If it is complete ruptures, single, what I can do it is splenectomy. Second problems, which is need to make the spleen surgery, is connected with diseases of the spleen. And from these diseases, primary, mainly, I will mention the problems which is deformation of splenomegaly, enlargement of the spleen. And as you remember, it is the group of the oncological problems. It is the blood cancers, for example, leukemias. And in that case, we remove the spleen to prevent the production of the blast cells, because here we have proliferation of the B lymphocytes. By the way, I want to remind you, if you forget, that for you, spleen, it is mainly immunity organ. Secondary, it is the blood storage place and some metabolism of the hemoglobin place. But for the fetus, it is also the hemopoetical organ. It is productive together with the liver, the blood. Postnatally will lose this function and it goes to the red bone marrow, as you remember. Let's say, once again, guys, surgeries which is mainly directed to remove the spleen, it's not so unusual. This is common. This is necessary, as I say, in two situations: trauma of the spleen and diseases of the spleen with the splenomegaly. We can have another situations also. For example, we can have parasital diseases like, for example, hydatid disease of the spleen. We can have, for example, abscesses of the spleen. But mainly, predominantly, it is these two positions. Okay. We understand what the importance is. I need to make access to the spleen, and I must make some technique of the surgical operation. But of course, if I need to make access, mainly I must know where it is located, the organ. Point number one from my subject, it is identification of organ location. Alo. Bari Luis. Լույս ջան, ցանտանեմ, պրոստը չեմ հասցնի, որտև այսօր իրար հետևից դասերի է։ 20 րոպեվա։ Չէ, այսօր առանց ինձ ցանտանեմ, այսօր, հա, դավայ լույս ջան, դավա ցանտանեմ, ապես։ Now look, spleen is located inside of the peritoneal cavity. Spleen is intraperitoneal organ. Spleen is covered by the peritoneum from all the sides, except the small hilum. In the place of the hilum, as you can see, for example, in this picture, we have the origin or finish of several ligaments. which is connected hilum of the spleen with peritoneal or extraperitoneal structures. That's once again, spleen is located in the peritoneal cavity and it is intraperitoneal organ. And why I mention about it? Because intraperitoneal structures is mobile structures, movable structures. We can move them. Meso and extraperitoneal structures, it is fixed structures. Okay. In which part of the peritoneal cavity it is located? In supracolic compartment. More of this, we can identify that this is the most left upper position of the peritoneal cavity. That's I put my hand now approximately in the place or location of the spleen. You can see that part of my hand located in my ribs. Part of my hand located below my ribs. And that it shows the dualistical projection of our spleen. Spleen is projected partly in anterior-inferior left thoracic region, partly in anterior abdominal region. That's why we come now to the projectional anatomy. If I need to make access, I must to know position of the organ towards the skin. That's why remember, please, in two parts of our body you will project your spleen. Inferiorly, it is left hypochondric region, which is part of the epigastrium. Superiorly, it is left anterior inferior thoracic region, which is part of the thorax. By the way, evolutionally, guys, such kind of position, it is, of course, protectional mechanism, because spleen behind of the ribs has much more better protection and several traumas will not damage it. Yeah. But unfortunately, spleen is very movable structure. Why it's so movable? Because primary it is intraperitoneal and secondary it is fused with the diaphragm. It has suspensor ligament, which we call phrenicosplenic ligament. And that is common rule for any organ which is connected with the diaphragm. If it is movable organ, each peak will be moved during the respiration. Then it goes to upwards during expiration. Yeah, organ will be lifted. Then it goes to down. Eta means diaphragm. It will be descending to down. How much? Look, to answer in this question, we must speak about the skeletal of our spleen. Length of your spleen approximately near the 10 centimeters. But your spleen projected by middle axillary left line from the 9 up to the level of 12 ribs. Let's say this is more than 22 centimeters. That's like into 6-7 centimeters, spleen will be moved to up and down. Is it understandable for you? We mentioned the projectional anatomy and we mentioned the skeletopy of the spleen. Now let's speak about syntopy, otherwise the location towards another organs. Answer of this question is simple, but first I should remind you the anatomical parts, because now syntopy we will describe according to the parts of the spleen. Spleen anatomically has two surfaces, two poles and two margins. Once again, two surfaces. One is directed to the diaphragm, we call it diaphragmatical. Second is concavely looked to the stomach, we call it the visceral surface. Spleen has two margins, one is looked to in front, second looked to behind, consequently anterior posterior. Spleen has two poles, one is looked to the diaphragm and touched to it, we call it superior, second to down, we call it. Now for each these mentioned parts, we will describe the syntopy. Let's start from surfaces. Now, diaphragmatical surface face to the diaphragm, that's why it's called diaphragmatical. Visceral surface look to the greater curvature of the stomach and to the tail of the pancreas. So remember, please, tail of the pancreas approximately reach the hilum of the spleen, between them 1 centimeter distance. Superior pole attached to the diaphragm, inferior to the left knee of transverse column. A left knee of transverse column is greatly visible in this picture. In front of the spleen we have anterior abdominal wall, behind of the spleen we have left kidney, suprarenal gland. That's all. This is all organs which is surrounded our spleen. Do you understand me, friend, or no? Are you sure? Tell me please, what is the anatomical parts of the spleen? 2 minutes before I told you that syncope we describe according to anatomical divisions of the spleen. How many parts of the spleen we describe? Don't worry guys, we are friends. Please. What? I don't need your help. I need help. Why now? Can you tell me why I asked you the question? Why especially for you, not to others? Don't think, by the way, that they know better than you. But why I asked the question especially for you? Your opinion, why I asked the question especially for you? No options? Because, friends, I know that for you it's not so simple to study comparable with another students. Because I know approximately level of your university. That's then I ask you question. I say many times, dear friend, try to be attentive. This is the cause why I ask you question. I don't want to anyhow confuse you. Believe me, you are good, my friend. I want to help you. This is the case why I ask you question. I want to say, friend, to be attentive, don't sleep in my lesson because you have problems which need to be improved. You understand me? This is important, friends. You must work. Why I say you don't write? You know, for me it will be much more easy to say, let's write everything, and during the class just to give you 1/4 of all this lecture and say, sorry, time is finished, go and study all another. But I make my work harder to give for you more information, more of this. I 100 times told you that you take pen and start to work. Mainly, you do mechanical work. You don't attract your attention into my speech. You try just to catch what I said and to write it. You know, guys, I don't speak just from my mind. I have absolutely proved medical investigations, psychologicals, which show that 80% of the people who make active writing don't understand what about they write. They just don't understand. If you will interrupt him and say, just repeated my previous sentence, 80% of the people will not be responsible. Because this is, again, I say you, in majority of the cases, mechanical work. How many years you are trained to do this mechanical work? Now, just calculate it from your first class of the school up to now. More than 12 years. You are just trained. Now I want to make another trainings, guys. You see, forget about this mechanical manipulation. Listen to me. Try to listen. What about I speak? And you know, again, medical investigations show that if you will ask, for example, from big auditory, how many people remember what about you speak, approximately 60% will not say you anything. You know why? Because, again, investigations show that listening 10 times more hard than writing. If you want to listen, you will make the big mental work. It's much more easy by very attentive face, just to look to your teacher and to make the show that you are inside of the topic, but in reality, for example, to think about your childhood. Again, I tell you, friends, that is not the time for meditation. Go your home, make the meditation how you want. Here you come to work together with me. Believe me, I spend huge amount of the energy during your class, and you will do it also. I don't need from you any physical movements. I need the mental work. Now let's again come to this question. So we understand the syncope of the spleen. Now let's speak about its ligamentous structures and about content of these ligaments. Again, you can ask me the question. By the way, I appreciate it that you asked the question. Unfortunately, I forget. Then last time your students, your group students, Generally ask me, I forget. Maybe I'm an old person, I have the memory problems, but you can remind me. But I forget, then you last time asked me the questions. For example, you can ask me a question, you can say, sir, why we need to know about ligaments? So I now directed this question to you, friend. If I teach you a very applied subject, which is mainly necessary to make the surgeries, not only, by the way, but mainly, why I need to describe any ligament, what it give me?
You're giving us information, like how to.
Can you come from Zulusian to the English, for example? Speak normal, understandable for you know. If I will speak in such a way with you, you will appreciate it. As I speak loudly, understandable, and of course with the meaning. Please.
So you're teaching us about ligaments because it can help us, it will help us in the future on like surgery.
And what? If something exists, it doesn't mean that it has surgical meaning.
Also, it can help us in everything, like to find out.
And you think that you give me the answer why I need to teach you about these structures due to the surgical importance? Your life is so simple, friend. It is just enough to product the voice, and in your opinion, you will give the correct answer. Voice production and correct answer, it is not the same, friend. To make the question, answer of the question to answer, really, you must make mental work. To product the voice, you must make the physical work. It is the just movement of your vocal cords. And that is absolutely not equal to each other. We need to know about ligaments from 2 points of the views. Point of the view number 1, ligaments make the fixation of the organ. And in majority of the cases, I need to make mobilization of the organ. Because it's impossible to work generally into unmovable structure. Can I move you from point A to point B if you are completely unmovable? That is impossible. What is the surgery? It is some manipulation with the structure. How I can make manipulation if it is unmovable? That's a point number 1 why I need to mention. Guys, in such a way, you will ask the question to yourself for any information which I presented for you. Why we need it? What it gives for us? Why we speak about position? Why we speak about projection? Why we speak about skeletotopy? Why we speak about syntopy? Now we come to the ligaments. And you will try to answer these questions. Otherwise, my subject will be very boring for you. It will be a collection of unuseful informations. But sorry, your brain is not storage. It doesn't remember anything which is unuseful. How else I can explain you? That's a point number 1. I need to make some mobilization of the structures. I should discuss. Point number 2. During this mobilization, I will damage the vessels and nerves, which is okay. Or I will avoid it, or vice versa. I will need to damage these vessels. For example, if I need to remove organ, I need to ligate the vessels, which is supplied. Otherwise, I will have bleeding. This is 2 importances of the ligaments knowledge. You must to cut the ligaments to make the organs mobile, and you must to ligate the units which is located inside of these ligaments. I think it's not so critical here. Not what do you tell me. Now compare my answer with your answer. I don't wait, then you will say something in the level of professor, for example. No, that is normal. But you will try to be logical. We speak about it because it is exist. Okay. Let's continue. Now, what is the ligaments of the spleen? Spleen has 4 ligaments. From these 4 ligaments, 1 is suspensor ligament, 3 is nutritional ligaments. Suspensor ligament of the spleen, you can see in this picture, it is the highest ligament in this picture. And we call it a phrenico-splenic ligament. From the spleen, it is descending to the upper pole of the spleen, from the diaphragm, sorry. And it makes the junction between them. As you remember 2 minutes before, I told you that symmetrically and synchronically, spleen will be moved with the diaphragm by this ligament, due to this ligament. Because it is fused, these 2 structural units, to each other. No any vessels and nerves inside of it. As I said before, generally suspensor ligament doesn't have any big vessels and nerves. Can you tell me why? Absolutely no. Movable is not only suspensor ligament, vice versa. Suspensor ligaments need to fixate the structure. But why they will not contain any big vessels and nerves? Why, for example, nutritional have, suspensor no. By the way, both have the same structure. It is duplication of the peritoneum. Why? Friend, if you don't know, why you don't ask this question to me? Do you wait, then I will ask it. You must be proactive, guys. I say you it 100 times. If you have some doubts, I will not deliver answer of these doubts to your home. You will ask me. Otherwise, I will continue. I cannot read your mind. I can only understand your speech. So if you don't speak with me, I don't recognize your problem, I don't answer, and I go to my another business. Answer is simple, guys, because the great big power is applied in these ligaments, because they fix the organ, and usually it is tensed structure. So if in tensed structure I will have vessels, number 1, they will be just closed, number 2, they will be ruptured. That is the case why I don't have inside of them any ligaments, any vessels. Another 3 ligaments which you see, 1, 2, and third one is cutted. You don't see it because it goes in the side of the stomach. It is 3 nutritional ligaments. It is a gastrosplenic, which is come to the splenico-colic ligament. Why gastrosplenic become to the splenico-colic? Everything is simple, guys. Now, I am the spleen. He is the greater curvature of the stomach. She is the transverse colon. Greater curvature of stomach directed not only to the spleen, but to the transverse colon. I think it is understandable. Right? By your faces, I see that you don't recognize anything. Now look, this is stomach. This is spleen. This is transverse colon. Ligament which is come from spleen from stomach to the spleen, then it is continuous to the transverse colon. We don't have real borders between them. Among of all these greater curvature, we have this ligament. Part of it which is directed into the left side and side of spleen we call gastrosplenic. Part which is directed to down we call gastrocolic. Let's say this portion can be called splenico-colic one. Because really they fuse to each other. We don't know, any painter doesn't draw here any border between them. It is understandable for this. Once again, the most superficial located ligament we call gastrosplenic. Tell me please, why not the splenico-gastric? Why gastrosplenic? Or it is just the randomly...
Because the nutritive vessel starts from the stomach and goes to the spleen.
Ooh, so sad. Really? Until now, I think vice versa. Vessels start from splenic artery and come to the stomach. Now you open my eyes, is there. Huh? That's why I call it gastrosplenic. Absolutely vice versa. Fundus of the stomach, as you can see, located a little bit higher than the spleen. That's an upper organ we put in first position, lower organ we put in second position. That's why we put it gastrosplenic ligament. Here stomach, Here spleen. What is higher? Of course. That is the answer of this question. I think it's not so hard. That's it. Now look, I am the spleen. This is my hilum. My right hand located in front of it. It is the gastrosplenic ligament and its continuation, which is splenic colon. My left hand, which is located deeper, of course, go to the retroperitoneal structure. We call it we call it renosplenic or pancreatosplenic. Why? Because tail of the pancreas and the left kidney located in the same level. Now, if you will imagine that my white cord, it is the parietal peritoneum, which is covered the posterior wall, these ligaments started in the same level. Yeah, that's a partly we call it from renum to the spleen, from kidney to the spleen. Partly we call it from pancreas to the spleen because they located in the same place. Once again, look to my two hands. My left hand, which is superficially to me, we call gastrosplenic. My right hand, we call pancreatosplenic and the renosplenic. What I inform now, the sac. This is the blunt sac of the spleen, saccus secus lienalis. As you remember, part of the left subdiaphragmatical space. And that is open to the right side, towards the pregastric bursa, which is the next component of this space. What is located inside? Okay, we understand the ligaments. Again, phrenicosplenic, gastrosplenic, its continuation, splenicocolic, and two others, yeah, renosplenic and pancreatosplenic. What is inside of them? Let's start from these deep ligaments, because functionally they are more important. They connected retroperitoneal space with the peritoneal cavity. Can you tell me why? Why retroperitoneal space must to be connected with the peritoneal cavity by ligaments?
For the blood supply,
What do you mean?
the major vessels are located in the retroperitoneal space.
Super. If I speak about spleen, which artery I should deliver from retroperitoneal space to you?
The colic celiac from that splenic artery is coming.
To say exactly which artery I must to deliver from retroperitoneal space to you, if you are spleen.
Splenic.
Of course. I think it is not so hard. Splenic artery should be directed from retroperitoneal space to the spleen, to the hilum of the spleen. Of course, I will do it by two ligaments which I described, renosplenic and pancreatosplenic. And really, guys, if you will look to the pancreatosplenic ligament, for example, here, you will see that it contains not only tail of the pancreas, but two vessels. More superiorly and more anteriorly, we have the splenic artery. More inferiorly and little bit backside, we have splenic vein. By the way, position is unique in the level of retroperitoneal space also. As you remember, splenic artery passed by upper margin of the pancreas. Splenic vein located behind of the pancreas on its posterior surface. And then the same position means artery up and anteriorly, vein back and inferiorly. They keep up inside of the pancreatosplenic and renosplenic ligament. And finally come to the hilum of the spleen. Then they come to hilum of spleen. Dear, this is answer of your question. Before reach the hilum of the spleen, they gives the reverse vessels towards the stomach. And by gastrosplenic ligament, they come to the greater curvature of the stomach. As you remember, it is short gastric arteries, which has come to the fundus region. And this is left gastroepiploic artery, which has come to the greater curvature. By the way, from gastrosplenic ligament, it is entering into the gastrocolic ligament and come up to the midpoint of the greater curvature. And here it make anastomosis with right gastroepiploic. Now my two hands show two vessels along the greater curvature. Descending is left gastroepiploic, ascending is right, and that is anastomosis between them. Remember, guys, I make the pictures not to have some value in the future, to, for example, sell it by Sotheby's auction and to have the money, but to use for the educational process. So use these pictures, otherwise they are useless. About the venous drainage, of course, splenic, we collected the venous blood from the spleen, and as you remember, it is directed behind of the pancreas. 2 minutes before we say about it. It goes to the head of the pancreas region, and behind the head of pancreas, it is fused with superior inferior mesenteric veins. Together they form the portal vein, which is passed to upwards, reach the level of superior horizontal part of the duodenum. And from that level, it is entering inside of the hepatoduodenal ligament. And together with two other tubes, one from these tubes we call the duodenum, and second tube we call the arteria hepatica propria. These three structures we call portal triad, DVA, ductus choledochus, vena porta, arteria hepatica propria. It goes to the porta hepatis, not make here the spleen. Eti means the portal vein. Can I ask you a question? Tell me please, why from the spleen venous blood should be passing to the portal vein? Because if I don't mistake, portal vein collected the digestive blood from digestive organs. But I am sorry, spleen, it's not a digestive structure. My question is understandable for you. Please. Please, no, options. Friend, what is happened? Say if you don't have options, say, sir, I don't have option. It's not interesting for me. Who can answer this question?
This RBC is digested in spleen into bilirubin and bilirubin.
Once again, you didn't answer in my question. Again, I tell you. Inside of the portal venous system, we have the blood which is need to be detoxicated, yes or no?
Yes.
Why from spleen this blood goes to the portal system?
Because spleen having the in spleen the hemoglobin is digested or
Not digested.
And
It is
it
break
break
into
down.
several components, yeah? GAM, for example, globin, gamma-siderin, different kinds, yeah? And she is absolutely right. They should be eliminated. And they eliminated by bile. Your liver also make the eliminational process. Not only your kidney make the elimination, not only your gastrointestinal tract. Fats is eliminated by urine, by kidneys, bile from liver, expirational breathing air by your respiratory system, several kind of the substances by your sweat glands. All these mentioned types of the excretions is necessary to clean our organism, but that is not complete answer in my question. This is only part of the answer in my question. Who can give me the second part of answer?
filtration.
What?
Filtration
Inside of spleen, you have filtration of what?
For the RBC, the old blood.
Can you remove your mask?
For old blood RBCs, filtration happens.
Once again, for all
Filtration.
blood, for
RBCs for RBCs, filtration.
no, that is not. I know that filtration is happening in liver. I ask why, especially from spleen, blood should be filtrated. And she said the first part of this question, because here we have the metabolites of the hemoglobin. I accept this answer, but I say that is not the common answer. There are a second component of this answer. No, I know.
Short gastric artery is drained into
Of
spleen.
course, because several digestive organs, like the stomach, drain inside of the splenic vein, and here we have absorption, and we need to make detoxification. Splenic vein collected the venous blood not only from spleen. That's why several gastrointestinal structures drain inside of it, and it need to be clean also. And this is understandable for you, friends. Remember, please. That's all. This is all what I want to give you about spleen. Lymphatic nodes located along the inferior caudal vein in retroperitoneal space. Innervation come from vagus and sympathicus. Do you have any questions? If no questions, now let's come to the intestine. You know, friends, except part of the duodenum, all another intestinal structures located in infracolic. By the way, in case of the duodenum, you remember parts which is above the papilloduodenum major, projected. I don't say they locate. Why I say projected? Why I don't say located in supracolic compartment? Maybe you. Why I say majority of duodenum projected in supracolic compartment, but I don't say majority of duodenum located in supracolic compartment. It is my just English problems? Is it? If it is not my English problems, explain please why I use these terms. Why not location but projection? Again I say you, is it my English or it is some meaning? What? So hard question, yeah. Teacher try to find the so. But it's more than simple, friend, because you have to pay duodenum mainly located in retroperitoneal space. Supra and infracolic compartments, it is parts of peritoneal cavity. It is parts of peritoneal cavity. That's why we speak not about location, but about projection. But there are one exceptional part of the duodenum, which is located in peritoneal cavity. Which part is it? Why you waste your time? In Yerevan, there are very beautiful places. Cafes, squares, theaters, museums. Why you come to this boring place? Tell me please. For what? I come, for example, here to teach you. For what you come here? Don't say just to study, because that is not the study. Of course, superior horizontal part of the duodenum, which is partly intra, partly mesoperitoneal, but anyhow located inside the peritoneal cavity. All another parts of your duodenum, descending, inferior horizontal, ascending, located in retroperitoneal space. Remember about it, about position, about location, about direction. If we speak about small intestine, generally I told you, from surgical point of the view, small intestine, it is jejunum and ileum. From anatomical point of the view, duodenum also part of it. Where is the start place of your jejunum? Jejunum started approximately in the level of L1, approximately 3 centimeter left to mid-length. L1, approximately. Friend, hold your hand like this. Oh, horizontal. 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 Thank you. If my friend, by his hand, will modulate it transverse colon, and I need to find the first loop of the jejunum during the surgery, the most simple way how I can do it, I will insert it, my finger, below the transverse colon, and I will push my finger from midpoint into the left side. Is it possible for you to hold this pen in this position? Then I will push my hand, my finger. Do you see it or not? Mm-hmm. Then I push my little bit, lift your hand because they doesn't see. Then I push my hand from midpoint to left side, I touch finally to one wall, which doesn't give me the chance to push it more. This wall we call the trace ligament or duodenojejunal ligament. And it's immediately located in transitional place between duodenum and jejunum. Thank you very much. So once again I tell you, you find the midpoint of the inferior margin of transverse colon. You push your finger from midline up to the left side, approximately 3 centimeters left. You touch to the sagittally located descending ligament, sagittally located, and that is the first portion of your jejunum. Because this ligament, guys, I'm very sorry, I will modulate it now. My finger, that is exactly this transitional place. I put my hand behind of my white coat. Why? To modulate it retroperitoneal space. Then it is perforated peritoneum, and from retroperitoneum become to the peritoneal tape. That's a rule. This border between my back and front part of the finger will be called flexura duodenojejunales. My white coat, which I tense above this transitional place, will be called the trace ligament or duodenojejunal ligament. That is immediately ligament which is touched to my finger. Inside of this ligament, by the way, we have the smooth muscular fibers. Then the food from your duodenum come to your jejunum. These muscles is constricted and they little bit lifted to prevent descending. Is it understandable for you? Write the name of the diagram. It is supplement of the inferior compartment of the peritoneal cavity. And let's do it. Guys, try to like your works. Otherwise, all your life, you will be pressed to do something. You must to enjoy your work. To enjoy your work, you must to understand it. To understand it, you must to study. I don't know another ways. Because we like only what we understand, what we know, what we appreciate. Let's start to make this diagram, and as usually I need to draw the aorta. From mid part of my picture, I will draw big tube. Then I will divide this big tube into 2 portions. And then I will divide these 2 portions again into 2 portions. And that will show for you all divisions of your aorta. Level L4, L5, yeah, your aorta divided into common iliac arteries. Common iliac arteries divided into internal, which is go to inside, external, which is become to femoral vessels, yeah, and supply your lower extremity. By the way, yes, I think you understand that this big tube doesn't locate it strongly by midline. This big tube located left to midline. So my midline will be approximately here. Do you understand me or no? The cavalry located right to midline, aorta located left. Then it is become to the midline. Bifurcation located, so it is come more superficially to the veins and split it into 2 terminal branches. Last time, guys, as you remember, we described first single branch of aorta in the level T11, T12. We call it truncus coeliacus. And from truncus coeliacus, we provided supplement to all supracolon compartment. Now we will come to next 2 single branches. It is the superior and inferior mesenteric arteries. Don't worry. As you remember, your aorta gives also double branches, pair branches, and pair branches subdivided into 2 groups. Do you remember the groups of the pair branches? Oh, anatomy. Anatomy is relaxed in our group. Parietal and visceral. Pair branches divided into parietal. For example, the renal arteries, it is visceral. lumbar arteries. It is parietal. Both is double, but one is supply organs, second supply the valves. But now I speak not about pair, but about single branching. So let's draw these single branches. For example, first one, let's draw in this level, put the letter A, and call it superior mesenteric artery. By the way, level of L1, if truncus coeliacus it is T11, T12, superior mesenteric artery located one vertebra below, that is the level of L1. Okay? And in opposite side, by the way, they doesn't direct it into the side, they look in front, but they cannot draw it in such a way. I directed it to the side, yeah? One vertebra below this level, I will draw the next single branch. Let's name it B. And of course it will be inferior mesenteric artery. That's all, guys. Your aorta doesn't give any other single branchings. This is 3 single branchings. Truncus coeliacus, superior mesenteric, and inferior mesenteric. All another its branches is pair. Now I should draw some organs, which will be supplied by these arteries. It is the intestinal organs, yeah? I will start it from the right side. I will draw here the sickle with appendix, with mesenterial appendix. Above it I will draw the terminal portion of the ileum. This connection junction, which you see we call iliocephal junction. Above it we have colon, below it we have sickle. Now let's draw the colon by its ascending part. Ascending colon. Of course you remember it will come to the right knee. Right knee. Then I will draw the transverse colon, which is turned into left knee. By the way, you can see that especially I draw the left knee higher than the right one, because right is pressed by the liver and descended to down. And you can see that I'm little bit more directed my picture into the you understand? Into the left side. Yeah, why? Because midline is here. Because I was to make symmetrical. Yeah, that's I little bit less draw it in the left and little bit more draw it in the right side. Because not my aorta is the midline. My midline is here. Do you understand me or no? Let's continue. Then I will descend this intestine to down, approximately to the level of L3. And then, in the level of L4, L5, I will turn it in sigma shapes type into the midline. From that portion up to this portion, I will have sigmoid colon. And then I will continue it immediately by midline. And I will draw the rectum. 3 portions, supraampular, ampular, and infraampular parts. Ampular, it is the most protrused part of this intestine. Picture is understandable for you. Super, but we don't finish it. I don't show for you the uppermost part of the small intestine. I show only the lowest part of it. Here is the upper part. Again, I find the midpoint of the transverse. I come approximately 3 centimeters to left, and I draw the second ring. This is flexura duodenojejunales, uppermost part of our small intestine. That is terminal part of the ileum, the lowest part of my small intestine. Now I take the green marker, and by 2 parallel lines, which is far from each other, approximately into half of centimeter, I connected upper point with the lower one. And I will put here the number 1. And how I will call the structure 1? Root of the mesentery. Thank you very much. That is place of attachment of the mesentery to the posterior wall. What is the root of mesentery? Now look to me. Little faster, yes. If I will open my white card, and I will ask you to take it now by your hands. Thank you very much. It will be the ligament which is come from posterior wall to the intestine. Thank you very much. Of course, between these two layers, I will put all vessels and all nerves, which is necessary for supply and for intestine. It is the ligament, nutritional ligament, which is connected posterior wall, otherwise retroperitoneal space, with the peritoneal cavity. I think it's not hard. Start of it located left to midline in the level of L1. Finish of it located in the level of the right iliac fossa. It is approximately L4, L5, first sacral ventricles. 20-25 centimeters. From this 25 centimeter, 5 meters of the mesentery will be started, which will come to all jejunal and ileal compartments and supply them. Of course, guys, the part of the jejunum which is near the upper ring and the part of the ileum which is near the lower ring will be fixed because their mesentery will be very short. Part of intestine which will be on the level of mid part of your root of the mesentery will have up to 25 centimeter mesentery and will be very movable. Idea is understandable for you. I'm happy. Now let's continue. We have all the necessary organ. Of course, I don't need to draw here 5 meters of the small intestine. I just draw the root of the mesentery. Now let's start to supply. From artery A, I originated a lot of the branches, which is enter inside of this root of mesentery. And by this root of mesentery, they deliver arterial blood to all small intestine. In my picture, these are second structures. And together they call the jejunal and ileal arteries. Up to 15, 20. By the way, majority will come to ileum longer. By the way, then you look, guys, look. Then you open peritoneal cavity. On the intestinal wall, it's not written, I am jejunal and I am ileum. But you understand that this is one continuous tube. How approximately we understand there is the jejunum. First of all, jejunum is smaller by diameter than ileum. Majority of the jejunal loops has horizontal localization. Majority of ileal loops has vertical. Majority of the jejunum located above the level of umbilicus. Majority of the ileum located below the level of umbilicus. But again, I say this is generally one continuous tube. That's an ileal and jejunal arteries. Minute attention to me. What is happened with these vessels inside of the mesentery? For example, I draw 5 from them. Inside of mesentery, each one split it into 2 branches, and between 2 neighboring branches, as you can see, anastomosis formed. We call it arcuate anastomosis. Again, it is split it into the branches, and again, between neighboring the branches, there are next arch formation. And like this, 4 or 5 times. I will not draw, of course, 5 such kind of communications. But from the last one, straight vessels, thank you very much, originated, which is immediately come to the loop of intestine. From its posterior margin, which is called mesenteric, by the way, opposite margin we call antimesenteric. Mesenteric, antimesenteric. And they supply intestine. If I will need to make resection due to any disorder like tumor, I will ligate it only the vessels which is supply this removable part, and I will keep the vessels which is supply non-removable part. I don't need to ligate that vessels. I need to ligate these vessels. Such kind of the arterial specificity gives the huge surgical opportunity. We can remove small intestine how much, how we want. You will see in the future that for large intestine, this rule doesn't work. Because in the large intestinal arteries, we don't have such kind of anastomosis. One artery, one part of intestine. Another artery, another part. If I ligated this artery, whole part of intestine, which is supplied by it, I must remove. We call it hemicolectomy. If here I can make portional resection for the large intestine, that is impossible. By the way, if I will resect this intestine, I told you it in my lecture time, I will make resection in such a way. Because if I will make resection line in such a way, here I will leave the angle without arterial supply. Mesenterical surface should be more than anti-mesenterical. I must have something like this. Only in that case, all this part of the intestine will have the supplement. If I will make incision like that, this angle will not have enough arterial supplement. Do you understand, friend, what I tell you? After you can say how connected these two. I say you each one in 120 degree, you can move. If you will move more, you can press these vessels. Or make, for example, strangulation. It is understandable. Super, I'm happy. Let's continue. Now let's come again to our picture. Next artery, I started from artery A and immediately descended into the cecal. In my picture, this is third artery. You can ask me how it is reached this ascending colon and cecal. Simply, friend, just remember what I teach you. Ascending colon doesn't cover by peritoneum from backside. It covered by tall fascia. And it immediately make the communication with retroperitoneal space. So from that place, artery come to its posterior wall, descended to down. Its continuation to downwards, we call the cecal. Artery number 3, we call iliac-colic artery. Iliac-colic artery. And look please here, in the level of the cecum, as you can see, it is split into two terminal branches. One in the level of border between cecum and between colon. By the way, this level, it is upper margin of the iliac-colic junction. Don't forget that your iliac-colic junction forms the valve, which we call Bowlgini valve. Bowlgini valve has great physiological meaning. Content can pass only from small to the large intestine and cannot make the retrograde passage. Otherwise, your patient will achieve heart dysbacteriosis because content in small and large intestine is absolutely different from each other. And more of this, artery 3 gives the branch into the mesentery of the appendix. In our picture 4, the artery, which we call appendicular. You know, in abdominal surgery, this is one of the most important arteries because appendectomy is one of the most usual surgeries. And if you don't want to remove the appendix, you should finally ligate this artery number 4. Not artery 3, but artery 4, inside of mesentery of appendix. Let's continue. Next artery, which is originated from A, come immediately to the ascending colon. In my picture, this is artery 5. We call it right colic artery. Again, how it achieve it? By retroperitoneal space immediately to the posterior wall. And here it is split into two terminal branches. One is go to down, up to the border between colon and cecal. And I will put here the small one star point. It will show the small anastomosis. There is, you know why this anastomosis is small, guys? Because if one from these two arteries will be ligated, it doesn't matter which one. Another cannot supply all these two compartments. In that case, you can ask me, but why we need this anastomosis? It can increase the supply into 20%, into 30%, then you have digestion, for example, need the more blood. But it cannot compensate the supplement of opposite artery. That's why, friends, I told you that for the large intestine, we make hemicolectomy. If one from these two arteries is ligated, whole part of intestine which is supplied by this artery should be removed. You understand me or no? Yeah, I can. You are one arch. You supply one part of intestine. I am another arch. I supply another part of intestine. In one point, raise your hand. We make anastomosis. But if you will be closed, this anastomosis will not be enough to supply all the intestine which you normally supply. You understand me? That's like, if I will ligate one from these two arteries, all part of intestine which is supplied by these arteries should be removed. Remember what I told you in case of small intestine. Huge amount of anastomosis, and you can make resection how much, how you want. Because not one artery is responsible for this supply, but huge amount. Idea is understandable for you. Super. So let's continue. Next artery, artery 6, coming immediately to the transverse colon. Ask me how. For example, ask me how it can come to the transverse colon. By its mesentery. Transverse colon, it is intraperitoneal structure. It has mesocolon. And mesocolon make communication between retroperitoneal space and peritoneal cavity. So it is enter inside of the mesentery and come to you. In the level of transverse, let's say this is structure number 6 in our picture. Call it, please, arteria colica media. Previous one is dextra, this is media, middle colic artery. And split it, please, into two branches. One is come to the right knee, second goes to the left knee. And again, in the level of the right knee, I put very small one, anastomosis place. Again, I tell you that is not sufficient to supply all ascending portion. 6th artery, this is last branch of superior mesenteric artery. By artery 6, superior mesenteric artery is finished. And another parts will be supplied by inferior mesenteric artery. Is it understandable for you? Okay, great. Now let's do it. From artery B, I provided the branch into the descending colon. How it come? From posterior surface, which has communication with retroperitoneal space. In my picture, that is the 7th artery. Call it left colic artery. Arteria colica sinistra. That's it. Now in my picture, you can see 3 colic arteries. Right number 5, middle number 6, and left number 7. First 2 from superior mesentery, last one from inferior mesenteric artery. And again, split it into 2 branches, one ascending, one descending. By the way, for artery 6, left branch, usually we call ascending, right descending, because left knee located higher than the right one. It is also important to be remembered. And 1 minute attention to my picture. Very big, huge start point. I put in the level of the left knee. Call it, please, the Riolan. Riolani, you know it is Italian surgeon. Riolan arterial arch. Why this point is so big? Because it's really very developed anastomosis. And you know we have the uniqueness here. If you look now to the level of left knee, only left knee, you will see that it is equally supplied by these 2 vessels. So if you make ligation of one from them, left knee don't need to be removed. Because another artery absolutely completely will supply the left knee. That's it. Is it unique? Yeah, because another parts of the large intestine doesn't have such kind of function. Let's continue. Next arteries from artery B descended into the sigma. You know what is unique? Not 1, but approximately 3, 4. How they come to the sigma? By mesentery. Sigma also is intraperitoneal organ, you know. And what is important, guys, look to my picture, please. They will form the arches inside of the mesentery. But not 4, 5, like in small intestine, but 1, 2. And finally, they will give the straight vessels into the sigma. In my picture, this is the 8 arteries. We call them sigmoid arteries. Again, 3, 4. And this makes the sigma unique, guys. Like the small intestine, we can make portional, resectionally, because several vessels supply with anastomosins. Let's continue. Next branch of artery B descended up to your rectum. How, guys? Simply, don't forget that inferior parts of your aorta goes from the retroperitoneal space to the pelvis. Pelvis and retroperitoneal space communicating to each other. And this is artery number E9 in my picture. Call it, please, superior rectal artery. Arteria rectalis superior. And in the brackets you can write terminal branch of inferior mesenteric artery. That's all. Inferior mesenteric artery is finished. This is the last branch of inferior mesenteric artery. What about lower 2/3 of our rectum? Answer is simple, friends. Until now, we have single vessels. Now, because your rectum is symmetrical structure, we will have double vessels from internal iliac. That's an internal iliac gives double branch into the middle third. In my picture, it is 10 vessels. We call it middle rectal arteries. And minute attention. Internal iliac gives one artery which is called arteria pudenta interna, number 11 in our picture. And pudenta interna gives the branch into the inferior part of the rectum, number 12, which is called inferior rectal artery. Understand me? It's not so hard. Internal iliac one gives pudenta interna. By the way, passage of this artery you know very well. By infrapiriformis aperture, it is come to the gluteal region, then by Alcock's canal goes to the fossa rectalis, and here it gives the supplement for your anal portion of the rectum. Now, very unique problem we have here, connected with venous drainage. Now look to me. Up to the level of artery 9, all veins which is passed with the arteries, and 9 also, will be drained into mesenteric veins. If the artery started from superior mesenteric, they will be drained into superior mesenteric. If it started from inferior mesenteric, they will be drained into them. But not for 10 and 12. 10 and 12 will be drained into internal iliac vein, which is drained into inferior caval. This is why here, immediately in this level, I show it by black, we will have portocaval anastomosis. Because above this place, venous blood drain into the portal system. Below this place, it is drained into the caval system. Remember about hemorrhoidal bleedings from this region. There are many reasons. One of these reasons, it can be portal hypertension. Then the blood try to shunt it from portal system to the caval. But I write here for you the special diagram which is show for you all these portocaval anastomosis here. And you can see that there are 5. From 5, 3 you know, one in anterior wall, caput medusa, second between esophagus and stomach, third one now between upper and middle third of the rectum. Where is the 4th and 5th? Of course, they will be between peritoneal cavity and retroperitoneal space. One, it is level of the spleen, splenic vein and left kidney. One, between liver, and again, now right kidney, portal vein and its branches, and right renal veins. Renal veins drain into inferior caval, portal one, of course, it is portal. Innervation is simple, yeah, you know, there are so-called autonomical innervation, yeah, Meissner and Auerbach plexuses, which is located inside of the wall of the intestine, large intestine, and which is make the vegetative innervation. Why we call it autonomous? because it can be under the brain regulation or it can work autonomically. Open the anatomy, remember the vegetative innervation. About the lymphatic drainage, it is regional lymphatic nodes, which is along the inferior caudal vein localization in retroperitoneal space. Questions? In your home, then you will read these topics, attract your attention just only into, especially into appendix, its positions. I want to remind you again, anatomy, appendix has typical position, otherwise we call it pelvic. Then it is passed from up to down and from the right to the left side and can come to the linea terminalis, which is the entrance into the pelvis. But then mesentery of your appendix is short. Appendix take the hook-shaped form. And this hook can be directed behind of, for example, cecal, we call retracecal position, or it can be directed to upwards or in right side. Sometimes genetically, ascending colon can be intraperitoneal due to some special genetical forms. In that case, we call the cecum mobile, cecum mobile. Because upper portion is movable, cecum becomes mobile, and appendix can be directed how you want, up to the inferior surface of the liver. This is problem, friends, because during the surgery you should find this appendix. And unfortunately, especially in hook-shaped forms, tip of appendix will be invisible. Usually students say, oh, no problem, let's take it and move it towards us. No, it's forbidden, because any movement can give the rupture of inflammatory appendix. That's why you will make two special type of the surgeries. You will be lucky if your patient will have only typical position. Here you will see whole appendix. You will start to separate it appendix from tip to base. What does it mean? Firstly, we ligate it, the artery, cut the ligament, and then cut the appendix, ligate it, and remove. Such kind of the surgery we call, guys, the retrograde, from tip to base. If tip is invisible, you must make separation from base to tip. Of course, you will waste the time. By short steps, you will finally reach it. God's know where it will be. This one we call anterograde appendix. And then we will study the surgeries. We will, of course, speak